Moving into vascular dementia, we defined it at the beginning of these slides, uh, a loss of cognitive function that interferes with the ADLs that is caused by cerebrovascular disease or circulatory disturbances within the brain. But basically what we're talking about are stroke, embolus, or thrombus-related strokes within the brain, usually caused by many small strokes, many TIAs, and the general decline of someone with Alzheimer's tends to be a sort of a slow decline with sometimes plateaus and then a slow decline with another plateau. The decline presentation of people with vascular dementia looks more sawtooth. It's like they're at this level and they had a little stroke and they brought them down, and then they continue at this level and they had another stroke, brought them down. So it's like a sawtooth presentation. Stair step would be the word. Versus someone that just has a big fat stroke and they're doing fine at normal, and all of a sudden they have their stroke and have a great deal of decline. And then hopefully they're recovering and working up from there. But usually, vascular dementia, there may be little periods of recovery, but because the disease, the strokes are eating away at the cognitive ability, they'll undermine the cognitive reserve. So there is some hope of rehabilitation, but usually by the time they're showing a lot of cognitive deficits, the brain has suffered a lot of damage, and they're usually quite old, and recovery is less likely. It is also common that vascular dementia presents simultaneously with Alzheimer's, and this is related to what I mentioned earlier, which is poor cardiovascular health predisposes you to brain disease of all kinds. Getting into Lewy body disease. We have two types, the mixed subcortical and cortical version, which is Lewy body dementia, and the purely subcortical version, which is Parkinson's disease. And Lewy body disease is the result of the formation of these little circular deposits of protein known as alpha-synuclein. And these are Lewy bodies. Lewy body disease, it's second only to Alzheimer's in how prevalent it is in our society. So you're going to see it a lot. Lewy body dementia, because it is both cortical and subcortical, it oftentimes is misdiagnosed. According to how the patient presents, it's often misdiagnosed as Alzheimer's, which is cortical, or Parkinson's, which is purely subcortical. So dementia with Lewy bodies, which is what this should say here, dementia with Lewy bodies, it's somewhere in between. They can have the cognitive deficits presenting with some of the motor deficits. So here is a list of symptoms, signs of dementia with Lewy bodies, which is what this should say here. And the red text indicates to you that that is a cardinal difference between dementia with Lewy bodies and Parkinson's disease. Because like I said, oftentimes these two things can because they're related, they can look alike at times, there can be misdiagnoses. So with Lewy body dementia with Lewy bodies, these guys have some early mild Parkinsonism, but not a lot. unlike someone with Parkinson's disease, that is their presenting symptom. Someone with dementia with Lewy bodies are going to show earlier mental decline, earlier cognitive deficits. You're not going to see that until late stage Parkinson's. People with dementia with Lewy bodies will have recurrent visual hallucinations, vivid hallucinogenic dreams sometimes. That is a cardinal sign. When you hear someone saying visual, bright, hallucinogenic, visual hallucinations, think strongly about dementia with Lewy bodies. People with this respond very poorly to antipsychotic medications, and it can amplify their problems and even cause death sometimes. They tend to have repeated falls. They tend to have earlier sleep disturbances, and an acting out of dreams is common. And this oftentimes, it seems like they're hallucinating in their dreams. It's like they are in a sort of half-wake state. They have recurrent delusions. They have fluctuations in autonomic processes like blood pressure up and down, body temp problems, constipation, urinary difficulties. So when you think about dementia with Lewy bodies, primarily how this presents different from Parkinson's is that earlier with dementia with Lewy bodies, you get more cognitive signs, less motor signs, but some motor signs, versus in Parkinson's, you get more consistent Parkinsonism, more consistent motor signs earlier, and cognitive deficits more later. The Parkinsonism, the motor problems with dementia with Lewy bodies can come and go. It's consistent with pure Parkinson's disease. Dementia with Lewy bodies, these guys have bright, recurrent hallucinations, acting out of dreams, delusions. So those things really should make you think dementia with Lewy bodies more than the possibility of Parkinson's disease. Also, people with dementia with Lewy bodies show no response to levodopa because their deficits are not the primary result of deficits of levodopa. But people with Parkinson's will show a positive response to L-DOPA, the drug that replaces levodopa in the brain, because that is what the substantia nigra makes, which is why their basal ganglia is not working, which is why they're showing their deficits. So moving into Huntington's disease, this is a nice little, I think this is the original report of George Huntington. I won't read it to you. You can read it if you want. But as all great neurological diseases, this one was identified in the late 1800s. What makes Huntington's disease or Huntington's chorea distinctive is that it is hereditary. It is an autosomal dominant. So you need only one copy of the defective gene to develop the disease. Huntington's disease is not near as common as Parkinson's or Alzheimer's, but it is out there and you will see it. And part of what's happening is that there is a mutant gene inherited from one of the parents. And this mutant gene produces a mutant form of the Huntington protein. So there is a protein that is the Huntington protein, and it's a normal protein, and we all have it. But if you have a gene that is producing a abnormal mutant form of this, then you will develop the disease. The typical age of onset is in the 40s or 50s, but there is a pediatric version of this disease. Primarily, what is happening in Huntington's disease is atrophy or the degeneration of the basal ganglia. And when we say basal ganglia, think motor learning, motor initiation, motor refinement, the atrophy of the hippocampus, the atrophy of the substantia nigra, the atrophy of Purkinje cells, which are cells connecting the cerebellum to the central nervous system. So there's an ataxic component in there from that. And then degeneration of the frontal lobes and the temporal lobes. So think personality, executive functioning, memory, cognitive deficits. So Huntington's disease presents very much with motor and cognition. The cardinal motor symptom of Huntington's disease is the chorea. And when we say chorea, we mean a slow, usually rotary kind of movement of the body. And it's very distinctive. It's pretty unmistakable after you've seen it a few times. Incoordination from the cerebellum, bradykinesia, which is difficulty initiating movement, and that could come from the basic degeneration of the basal ganglia or the frontal lobes, and changes in cognition and language. Suicidal thoughts, tendencies is a particular risk of diagnosis with Huntington's disease. They don't know if it's because it's an emotional reaction to the negative diagnosis, or if it is a result of the illness itself. The prodrome of Huntington's looks like a great deal of restlessness, sleeping problems, incoordination anxiety, irritability, maybe a loss of a sense of smell. And this happens with a lot of degenerative diseases, such as Parkinson's and Alzheimer's. You'll occasionally hear about that. Huntington's is divided into 5 general stages. I'm going to sort of cluster these into 3 stages. Stages 1 and 2, this is the motor symptoms have begun. You're talking rigidity and bradykinesia, difficulty with motor initiation. There's early cognitive changes in this disease that are highly characterized by personality changes, maybe some early anxiety and aggression that you're not going to see in other similar diseases. This is going to evolve into stages 3 and 4, and this is about 4 years post-diagnosis. And at this point, the chorea, the hyperkinesias, begin to negatively impact speech. The patient begins to become more dependent on caregivers for the completion of their ADLs. They can still walk, but the chorea is such that they begin to have significant fall risk. Moving into the 5th stage, or the 3rd stage as I have it clustered here. At this stage, late stage Huntington's, the patient is fully dependent on their caregivers. The physical deficits at this point have overtaken the cognitive and the language problems as being the most inhibitory deficits for them. They are non-ambulatory at this point. They're showing great problems with deglutition, so aspiration risk becomes very high. They're showing severe memory loss, and usually they're going to die from the lack of motor problems that's going to cause aspiration pneumonia or an inability to eat, creating just a state of anorexia, or some secondary medical issue like bed sores, some other secondary medical issue like bed sores or pneumonia or MRSA, which is a hospital-borne illness, those kinds of things. Okay, last dementia we're going to talk about is Pick's dementia. And also, here's some good links you can follow. Pick's disease, like I said at the front end of this lecture, is a form of frontotemporal dementia. This is the frontal or the behavioral variant. So if the frontal lobes are going, then you're going to present primarily with frontal lobe deficits. Average onset is between 50 and 70 years. Lifespan is 2 to 10 years post-onset. And the primary symptoms look like frontal lobe symptoms: compulsive, lack of judgment, lack of executive functioning, socially inappropriate behaviors, maybe some repetitive behaviors. These guys tend to have an apathy towards their disease. They're usually not very worried about having a disease. They can show language deficits because, of course, the frontal lobes are degenerating, and one of those is the left frontal lobe. So, early to mid onset of behavioral, emotional, and personality changes, as well as decreased verbal output, poor artic perseverations, and echolalia. Contrast that to the mid fluent speech and impaired memory of Alzheimer's disease and later loss of language. So this looks very different from Alzheimer's disease. There's more emotional problems at the front end. Personality changes can be dramatic on the front end, unlike people with Alzheimer's. Also, there is something called early onset Alzheimer's disease. And this is essentially the onset of Alzheimer's, I believe, prior to the age of 55. Maybe it's 50. It's around that area. But it's the same disease process. It's just simply an earlier onset. And there's early onset Parkinson's disease as well. That's what Michael J. Fox got, or what he has. And all of these diseases, what we think now is that by the time you're showing symptoms, you have had the disease for quite a while. So if intervention is going to occur, now we're thinking about medical intervention that's going to occur well before you're showing symptoms. Because what we're thinking now is once you start showing symptoms, it's probably too late.